Good afternoon, everyone. Good afternoon. I'm Shri Zahir. I'm Dean of the Carlson School of Management, and I'd like to welcome you all to First Tuesday. Thank you so much for joining us here, both in person, and I know there's an audience joining us virtually on Zoom as well, so welcome to everyone. This is an event I think I must have planned that. Anyway, this is an event, as some of you may know, which has been in the planning for quite literally months in the making. And for those of you who don't know, this discussion was originally scheduled back in August. And unfortunately, that time we had to postpone the event because of a gas leak on campus. Yes, I know we've had other explosive news, but not as bad as the gas leak. So I want to thank all of our panelists for coming back and being here with us, and have my fingers crossed that there won't be any more explosions before we go on with something that's happening today. So before we get to our panel on the future of the healthcare industry, I'd like to recognize First Tuesday's long-standing partners, Wells Fargo and Twin Cities Business, and of course, a very special thank you to the many, many Carlson School of Management and University of Minnesota supporters in this audience. And so it's a thank you all for everything that you do for the university and for the school. Today's panel will focus on the future of the healthcare industry, and we're joined by three extraordinary healthcare leaders who will share their perspectives. Jakub Tolar, our own Dr. Jakub Tolar, who will moderate the discussion. He's the Dean of the University of Minnesota's Medical School, Vice President for Clinical Affairs at the university, and he's also a co-leader of mHealth Fairview. Then Jakub will be joined by Dana Erickson, who is the President and CEO of Blue Cross Blue Shield of Minnesota. And in that role, she's responsible for overseeing the strategy and operations of the state's largest nonprofit health plan. And our other panelist is Lisa Shannon. Lisa is the President and CEO of Allina Health, a role she was appointed to at the beginning of the year. And prior to being named CEO, Lisa served as Allina's President and Chief Operating Officer. Everyone, please, a round of applause for Jakub, Dana, and Lisa. With that, Dana and Lisa will give some opening remarks, and then it'll be followed by the panel discussion. So I invite Dana up to the podium. Thank you.
No, there we go. Just had to wait a second. So thank you for the introduction, and thank you all for being here today and for what is starting out much better than in August, right? I think we didn't even get to our salad when we met last August before we had to leave due to the gas leak. So really looking forward to this event today and to spend some time with my colleagues in healthcare. So before I get started again, Dana Erickson, I lead Blue Cross Blue Shield of Minnesota, and I just want to spend a little bit of time sharing with you today something about that organization. Many of you may know Blue Cross or have worked with them in the past, but I'd love to just share a bit about the Blue Cross system in general. The Blue Cross system is actually nationwide. It is the oldest healthcare company in the country from an insurance perspective, and it is actually comprised of 34 independent and locally run organizations across all 50 states, plus the District of Columbia and Puerto Rico. So we actually have a very broad national presence. We are proud to focus on working with our provider partners across all of those areas to ensure access for our members to high quality, affordable, equitable health care. So that is a cornerstone of what we do across the country is our network. And we are also proud to be the choice of many employers across the country that are seeking to provide access to health care for their employees. And we are really proud and honored to be chosen by 79 of the Fortune 100 companies across the United States as their healthcare of choice. But I want to take a step back now and just talk about Blue Cross of Minnesota, because I think we are the best Blues plan in the country, of course. That's right. So we were founded in 1933 actually as a prepaid health network in partnership with 7 hospitals in the Twin Cities area. It was the Great Depression. Think about that time. People needed health care, but actually just could not afford it. Hospitals sat empty because people could not afford to go to the hospital when they needed to. So that's how we started, actually in partnership with providers in our state. We currently serve as the state's largest not-for-profit health plan in Minnesota. We cover 1 in 3 Minnesotans, and we are very proud to say that it's our mission to be accessible throughout the state and through all products, whether that's employers who choose health care, that's individual purchasers through Medicare or the Affordable Care Act, individual market, and federal, state, and local government programs, so medical assistance, Medicare, and federal employee programs. You'll see that there's an image there on the screen. I have this actually hanging in my office, and it's the first image, if you will. It was actually an advertisement of that Hospital Service Association. That was the name that we started with in 1933. And I love to point out 2 things. One is the name Blue Cross actually came from this picture. It wasn't Blue Cross, it was Hospital Services Association, but that didn't really roll off the tongue. People just didn't remember that, but what they remembered was the Blue Cross on the arm of the caregiver. And as a registered nurse, I'm always so proud to say that the name of Blue Cross came from the caregiver, right, that was caring for the patient. And so that's how it became the Blue Cross plan. You'll also notice it costs 75 cents a month. That is different than it is today, but a good reminder of things as we progress. And last, I just would love to share with you a couple of milestones. We are celebrating our 90th year in existence this year in 2023, which we are immensely, thank you, proud of. And as we'll talk about today, there are a lot of challenges in healthcare. But as we think about that within Blue Cross, a company doesn't stay around for 90 years if they don't know how to pivot, if they don't know how to respond to the changes that are happening in the market. And so we will do the same. We continue to do the same, as many of you do as well. Very quickly, I want to highlight a couple things. We launched in 1933. 1986, we launched a foundation that we're extremely proud of. It's a private foundation that is funded through the health plan. But every year since 1986, we provide, through grants, millions of dollars within the state of Minnesota to communities, community programs that are focused on healthy communities, racial health equity, and generational longevity across time, if you will, and across the state. We also partnered with the state of Minnesota around a lawsuit against big tobacco back in 1998, which then launched our Center for Prevention, which is, again, another initiative where we are able to provide funding to the state of Minnesota around policy, tobacco cessation, healthy eating for our kids, and exercise as well. So we are honored to be here today to share that with you. And with that, I'm actually going to invite up Lisa Shannon to share about Allina.
Thank you, Dana. Think you can hear me. It is really good to be here in a much calmer environment than the last time we were here. And I think about, well, we've learned a lot since the last time we were here, so we have more to talk about. We have more to share with all of you. As mentioned, I'm Lisa Shannon. I have the great privilege and honor to lead Allina Health, an organization with roots going 140 years back in the community. And I always say that, you know, I've been in healthcare my whole career. Started actually as a dietitian and made my way through a variety of leader roles. And I believe 2 things at my core. Number 1, the best care and the best outcomes are delivered by teams of people with equal roles to ensure, different roles, but equal responsibility to ensure the best, safest quality outcomes. And I see that every day unfolding with the wonderful team at Allina. The other thing that I have grown to increasingly appreciate is that to be able to lead in an organization providing care to community, to many of you, to my family, and to be able to lead a service that the people I love most use at their most vulnerable times of life is really quite an honor and a really heavy responsibility as we think about, today we'll talk about some of the headwinds that are facing healthcare, particularly in nonprofit healthcare. Many of those are industry level trends that predate a pandemic and maybe were made a little more intense coming through the pandemic. And yet, I remain incredibly optimistic that we have an opportunity to change an industry that frankly has been for years and years in need, decades of change to ensure access, affordability, and really the highest quality and safest care, particularly for our most vulnerable population. So a little bit about Allina, and you know us, and many of you, of course, in this room use our services, and we're proud to serve you as well. But as I mentioned, our mission is deeply, deeply rooted in the health of communities and health of individuals. In the pre-reception, there was some discussion about, you know, what are the trends in our country? And I always say, when you think about your vital signs that determine your health, if you haven't had a physical exam recently and you don't know your numbers, I encourage you to know your numbers. The number that will predict a person's health and life expectancy is one number, and it's their zip code. And how we think about zip code and health and where we serve is what we're spending a lot of time on individually and with partners like Blue Cross Blue Shield of Minnesota. So you'll hear that through our remarks. So a little bit about us in the numbers. We proudly have a little over 29,000 really committed caregivers and many sites of care. We get to provide service to hundreds of thousands of Minnesotans and Wisconsin, everything ranging from birthing of babies to physical exams on through very, very complex care, particularly at Abbott Northwestern Hospital and others. One of the areas that we've been really focused on is how do we take care out to community? And taking care out to community means first at home. And so what you'll hear more in our remarks is part of affordability and access is bringing care to our communities. So we have a very successful hospital at home program that seeks to ensure care you can't get much closer. And last I checked, people tell me their beds are more comfortable than ours. So we try to get care as close to the community as we can, and our ambulatory platform, including our surgery centers, to take that which we can provide safely as close to an ambulatory in a more affordable way as possible. Lastly, maybe I'll wrap up with this. And this is a deep commitment that we share with so many of you. And it really is a deep, deep responsibility, particularly for an organization whose headquarters is mere blocks from where George Floyd was murdered. It has always been important to us to create diversity, equity, inclusion. It has always been important to us to think about social determinants of health, to screen our patients for that which is the highest risk factor. When 1 in 5 of our patients have food insecurities, and there are housing insecurities, and there are safety issues, and those affect our communities of color disparately, we have continued to move forward a path toward diversity, equity, inclusion, and belonging. And on February 2nd of this year, I had the great honor of bringing our management team, the first time in 4 years, together in person for a day together of shared learning and collaboration, and was able to roll out a purpose statement that I deeply believe Allina gets to serve differently in community, and that purpose is really anchored around belonging, but it really is a purpose that at the bottom of the slide reads that we exist for the flourishing of humanity. And flourishing of humanity, for me personally, at a deeply personal level, is about post-traumatic growth. And all of us, we all have stories. And we have stories of moments of our lives that was the hardest thing we ever experienced. And not in the moment not years later, but at some point we come on the other side of that with some form of flourishing and some growth. And I would say when I think about the healthcare industry right now and what we've been through, we're poised and not yet there. And we have caregivers that are still sitting in not post, but traumatic. We have community that need us because they have delayed diagnoses, they have access challenges, they have food insecurities. And so we're really focused on that. And the last thing I would say about the flourishing of humanity, I really believe it's an inside-out job. And that means that we have to start with our people. And so often I get asked, what are you most worried about? What keeps you up at night? And it's the same thing over and over again. It's our workforce. Our workforce, they are weary. They've been through a lot, and they are deeply, deeply committed. And so flourishing starts with our people. It's about their belonging and their resources and support and healing and well-being. It's about our patients, all of you, if we have the privilege to serve you. It's preventing illness. It's working with you if there is illness to ensure coordinated, seamless care. It's also about our community and where we show up to enable health, better health and better access for care. And then it's our planet. And by the weather patterns, clearly is not flourishing. And so how do we come together for our people, our patients, our community, and our planet? And I'm excited to be here and have the conversation with you today. Jakub?
Well, thank you, everyone, for being here. I'm going to first do the shock thing. I'm going to be the first one not to mention the gas leak. How's that? It's okay. No emergencies here. We are all good. Thank you for gathering here. I am bone marrow transplant physician. I have very good first-hand understanding of what it means for my patients to get sick. So the typical scenario is that there's an 18-year-old that has a leukemia, and not only that, it's going to break her life. I have to explain to her that she may not have children ever. I have to explain to her that she's going to lose 2 years of her life, and maybe she's going to live at the end of that. To explain that to the family. And then, wait for it, middle-class Americans, her parents will lose their house, their grandparents will lose their house, they will be deeply in debt for a very long time. And that is on top of that primary diagnosis. So my proposal to you is that to continue on the themes that Dana and Lisa, and we know each other, we agree with each other. This has to change. I mean, we know what's wrong. We know how to fix it, but nobody wants to do that. So look at this way. Healthcare, I also should say that I trained on both sides of the Atlantic, so I have some understanding what it looks like practicing as a surgeon, as a transplanter, as a physician in different systems. And I can assure you that we are lagging. We don't have a good system here. And the reason for that is not medical. This is the best medicine in the world, in my opinion. That's why I came here 30 years ago. But the challenge is that the healthcare economy is divorced from the healthcare delivery. What I mean by that is, and we'll get to this in a minute, but just look at the $4.5 trillion economic sector in the United States, 19 or maybe 20% of GDP. The largest, bigger than retail, okay? That's over here, along with my 18-year-old with leukemia with no hair. And here is that 41% Americans have medical debts. That's 100 million people. 1 in 8 Americans have a medical debt that's more than $10,000. About 60% of debt collections in this United States is because of medical debt. I mean, you don't have to be, you are a glorious economist, and I'm grateful to Dean Zahir for hosting this, but this is just wrong, okay? All right, so I'll start with asking my friends over here, how is Blue Cross Blue Shield, how is Elina gonna lead through the transformation that will get us from talk and empathy, and I'm for empathy, to actions, to something that actually matters to patients, to nurses, dietitians, clinicians, and real communities. How are we gonna do this? Lisa.
Yeah, well, when you, I appreciate all those remarks and the challenges that are facing access in our industry are profound. And when I think about cost of care, and you use your specialty as an example, an early detected cancer is a much more affordable cancer to care for. A prevented cancer contributes to a different life outcome where possible, and we know that isn't entirely possible. So part of what you'll hear, I think Dana also talk about, is the partnership that we forged, and Dr. Penny Wheeler's here as part of my predecessor, who was very involved in our Blue Cross Blue Shield collaboration to look at an opportunity for us to find a way to integrate care and coverage, to really reward providers and health systems for what we called whole person care, for getting on the front end to grow ambulatory lower cost settings for care, to work toward preventing ED visits, unnecessary ER visits, to ensure that we were providing education, care management. So you're gonna hear a theme, I believe, from all of us around affordable care starts really early with prevention, and it starts with understanding patients, which is why in every primary care practice that we have now, you'll see social determinant of health screening, because we have to understand the nature of their vital sign, which is their zip code. And we also have mental health care embedded, and I'm sure we're gonna talk more about mental health. But as it relates to how do we get on the front end of some of those systems so that we can reduce unnecessary utilization.
Yeah, I think fundamentally, the way we approach, I'll talk specifically about what we're doing or what we started and are still doing, right? We'll continue. Was just a recognition that the status quo, to all of the points that you made, all the data points, right, that demonstrate the status quo is not working. And most importantly, it's not working for our patients. And when we first started to talk, we were not in a great place as two companies, frankly. And I think that historically, and just talk about that openly, right? That there can be this disconnect between the finances of healthcare and the healthcare delivery that can become contentious. We know this. And there really had to be a coming together to say there has to be a better way to do this, ultimately for our patients, communities, members, whatever language we want to use around the people that are trying to consume healthcare. And so it's had to start with that. We have to think differently about what we're doing together, and an immense amount of trust, quite frankly. And this is something I think is a bit unique. And Lisa, you talked about this a little bit in your opening remarks about the not-for-profit system in Minnesota. You know, I talked about our 90-year anniversary. We're pretty committed to Minnesota. We're here for the long term. And so we can take and are willing to take different risks, if you will, from business perspective as a not-for-profit health plan over the long term when we believe it's the right thing to do for the community. And we have the luxury of doing that with like-minded partners. So that's how we came together to say, and especially as the payer, how do we not be a barrier to people accessing care, and how do we not be a barrier to providers who are looking to create these models that get more upstream, that are more preventive? How do we work with community, whether it's lifestyle, well-being, mental health, that quite frankly in the old, if you will, which is actually the old is current, fee-for-service structure doesn't get reimbursed, right? How are you supposed to invest in those capabilities and be creative in care models as a provider if you receive no revenue from that? It's just the reality, right? So that's what we really worked on, starting with what is it we're trying to get to, how can we as the payer create a financial model, a payment model that allows the creativity of the care provider toward the common goal that we all have. And we don't by any means have it all figured out. But what we do is we have a shared commitment around this over a longer term period to continue to figure out, let's try something, let's iterate, let's try again, let's try again. And I think that trust has to be there and that long-term commitment has to be there.
Maybe I'll give a maybe tangible example if I could. So the development of ambulatory surgery centers in our community, you would expect the routine orthopedic things that can happen, that ears, you can imagine, a number of things that we do in ambulatory surgery. Well, we have worked really hard to bring our specialty providers in. So the Allina Health Minneapolis Heart Institute on December 8th in an ambulatory center, surgery center, did a first pacemaker placement in the Midwest, where we have the very first cardiovascular ambulatory surgery center really in a multi-state region. And we're able, through innovation, clinical collaboration, the right patient selection, to be able to do a procedure that would previously have been heard of in the hospital. The costs were less, and therefore, of course, the reimbursement was less. Now, that particular patient was not a Blue Cross patient. And
how dare?
And sorry, Dana.
It's okay.
I know. And
I
what
know.
it means, though, is that sometimes incentives are not aligned.
Yeah.
And so we did the right thing for the patient. We did the right thing for the payer. We did the right thing for the employer who sponsored that payment system. And the physicians, I got a picture after they got out of the OR, no private identifying information was in it, but they were just super excited about it, and we lost money, a lot of it. And we did because that reimbursement was not commensurate with the expenses, and had we taken that patient to Abbott Northwestern, we would have made money. And so we have to align the economics with the care so that we can do the right thing and everybody benefit from doing so.
That's right.
Yeah.
I agree. That's why I admire these women. So let's do this. You started, Dana, very well on the fee-for-service,
Yes.
and this example is a wonderful one. But how do we go about this equilibrium? Because what we are all saying, is pretty simple. You get paid disproportionately for things that are totally idiosyncratic compared to others. What I mean by that is, and I worked on both knees replacements and something that's more in prevention, there's absolutely zero reason from the patient or the clinician perspective why you would pay 10 times or get reimbursed, 10 times more for, I hope there are no orthopods here, for a knee than you get for preventative medicine. And yet, or diabetic, put the cakes down, please. Your diabetic
Everything
prevention.
in moderation.
Okay.
Everything.
So that is the cause where you,
That's right.
Dana, started, this economy that doesn't work. And Lisa, what you said, the incentives are just plainly not aligned. Because you have a hospital that is struggling to get as much volume as possible. And to be frank, doesn't actually matter whether it is indicated or not. How much volume actually matters. And then you have the insurers, either indemnity or a third-party payer, whatever that
flavor.
is. And the more claims you process as the company, the better you get paid. So the formula is actually pretty simple. It's a zero-sum game. It's shifting costs, and each cost is somebody's revenue. So there's not, a good rationale, from within to change this. And the problem is, and I'll wrote on the question, is the transparency. So everybody is about, let's do transparency, but there's no transparency possible at the moment because there's no link between the cost and price, because these are purely negotiated In the bundled payments, they are, you get paid for, you get discounted because you are in the network, right? The bundles sometimes are just fee for service that are bundled together, right? So this disconnect prevents the customer, which is, I don't like that word, but a patient or somebody, community doesn't, or employer for that matter, has inability to act in a market value. Because there is just on that invisible hand, there's an invisible finger on the scale, that is outside of what is connected to the patient or the provider. How are we gonna change that? They like the question. Okay,
Yeah.
go.
So speaking specifically to transparency, I think,
Yes.
that's because I think that's a tool, right? The fundamental underlying issue that we're talking about here is a misalignment of the financial payment for models versus the care delivery itself. And so that has to be still at the foundation of everything that we're doing to try to decouple, right, the payment from transaction, more procedures, more revenue, and really be paying for those outcomes that we want, which is around preventive service, predominantly preventive services. To Lisa's point, I would say a really good negotiated lower ER rate is good. You know what's even better? No ER visit. No ER visit, because we actually prevented it from happening. And so that still has to be the fundamental philosophy, if you will, that we're working toward of bringing the payment together. Specific to transparency, I agree with you. This is very, healthcare has been different than any other industry. If you're getting your roof repaired, you know about what it's going to cost, right? You've got some estimates. Very different. There's been legislation around transparency. I've been in healthcare my whole life as well. Been on the payer side, 20-ish years. We've been working on this on the payer side for a long time. I think that some of the newer transparency laws that have come through are really trying to seek to provide additional information into consumers' hands on the payer side, everything from, if you look at your insurance card in the past 2 years, you may not have noticed it, but it actually has on there now. What is the out-of-pocket cost? What is the copay by product? Some of those fundamental pieces. But how do we take this data? It is very complicated, to your point. It's negotiated rates, it's discounted rates, it's, this benefit plan versus another benefit plan. So how do we as payers provide that in a way that's actionable? And that is, I still think, what is missing at the consumer level, but where we're working on. We have been investing in working on an app. It's not just an app, actually it's a tool within our enterprise. It's called Blue Care Advisor, but think of it as a navigation tool for a member that's trying to do the right thing. And by the way, it has to be personalized. If we just put data out there of 5,000 lines of information about cost, I don't know what matters to me. I don't even understand half the codes. What am I looking for? But how do we serve it up to someone in a specific way? I'm getting ready personally to hit a milestone birthday. I'm not afraid to share.
21.
21, okay. That's exactly right. I'm legal. No, but I'm going to start hitting some tests, right? So I want that app, that information to say, Dana, you're going to have to get these things done in the next 6 months, and here's what it will cost you depending on where you go. Make it personal to me. That's what we're focused on. How do we take the data and the transparency rules, if you will, that have come through? Philosophically, I support transparency. We have to support transparency for people to make better decisions. But we need to serve it up to people in a way that makes sense. They're not going to go out to a website and search 5,000 rows for something that they're still not going to feel confident at the end of the day that that's actually how they need to plan their budget, right? That's at the end, I've got to pay for this out of my HSA or out of my savings or whatever that is. And if I don't know, guess what happens? They just don't get it. They just don't get it. And so that's what we're focused on, is how do we take the information that we have. Certainly there are transparency laws that we are adhering to, but we need to take it a step further and actually provide it and serve it up in a way that's personalized to members. That's what we're focusing on. So we have to align the incentives, fundamentally still have to work on that day to day, and then how do we take that information and put it in the hands of consumers and, not to get on my nursing soapbox, and get them to care. Because I still think that there's a big chunk of people when we create these tools that are just do not think about shopping for healthcare in that same way. Maybe it's that consumer mentality, Dr. Tolar, that it feels different for healthcare, and I think that's fair oftentimes, but we just got to continue to provide information so people can make the best choice for themselves and their families.
And I'm so glad that you mentioned trust at the beginning, the
Yes.
fact that you are working and thinking together. That's exactly the secret sauce, in my opinion. So, Lisa, how is this going to happen if you have anemic margins, diminishing volumes, degraded payer mix, losing $1.5 million a day, in healthcare systems? How is the value-based care going to happen? How do we get from fee-for-service to fee-for-value in this environment?
Yeah, so I might say some things that are controversial, and I'm not sure who
good.
else is in the room. So I'm talking for a friend of mine who told me this, and so let me start with that. And so what you're ultimately, if you back all the way up to the economics of healthcare in our country, most, again, for a friend of mine, most health systems, 60% of their payment is not a Blue Cross Blue Shield of Minnesota. It's the government. It's our Medicare or it's Medicaid. And if we did a business case study and took a $100 bill and said what percent of that $100 bill goes to pharma, med tech, insurance companies, for-profit niche competitors, Amazons, et cetera, all the disruptors, physicians, hospitals, you just go down the value stream and you would see the compression that is happening. And in most communities, doctors and hospitals, especially coming through the pandemic and the labor cost pressures and the access pressures, the problems are not full hospitals, they are overflowing. They have, today at Alina, we have 120 patients out of our 1,600 that are in beds, but they don't need hospital care. They need a nursing home, they need a home. They're homeless. They need a place to receive post-acute care like skilled nursing. Well, guess what? All those people are struggling with labor. So there's not enough nursing home beds, there's not enough mental health care. But we see them because our nonprofit charitable asset of the community doors are always open. And so we will always provide, but what that stresses and strains in the system are, nurses, doctors, beds being held for patients who really should be safely cared for in other settings. The economics, what we know about government reimbursement, it does not pay the bill and it gets shifted to commercial insurance. And then you add bad debt on top of it and you add rising supply chain costs. We could talk a long time, and since this is a business conversation about, and it is our obligation and our responsibility to solve it. And all of that, so that I'm gonna get a little more optimistic. Now I'm back to me, that was my friend. And so now for me, what I would say is that we have to have payer partnerships that reward for value. And happens to be that Blue Cross Blue Shield of Minnesota is our #1 commercial payer. But when you looked at our $5 billion of revenues, that is still of our commercial payment model. And so how we have partnerships that ensure our doctors and our caregivers and our facilities and all the supply chain deserves their fair share, the pharmacies and certainly pharma and the device manufacturers. But from a economic standpoint, the reward really has to be integrating care and coverage so that we stop paying for only things that incent unnecessary utilization. And that requires a very big cultural and structure change within an ecosystem, which it starts with a contract, but it also starts with behavioral alignment. And I have to say, as a dietitian as well, it's about lifestyle engagement in a way that patients can actually engage in. If they're in a food desert, or they're homeless, or they have other challenges, it's not safe to walk in their neighborhood. Where will they walk to have physical activity? And so that's why I think it's gonna take all of us working together, and there's no secret sauce, and this playbook is being written.
Very, very good.
Yeah.
Applause. Okay, thank you. You know, I have this train with this down. Very good, very good. So how do we look at the alternative models? Because what I'm seeing is, you know, this is not the first time that you know, people like us having this discussion. This has been known for decades, you know, and there has been different ways, you know, and the pandemic, of course, did not cause any of this, but unsurfaced, you know, like war does, you know, the gaps that already exist in the society. All right, so the top-down didn't really work, you know, the reforms in this United States. How about the ground up? Because we, you know, share another thing. You know, we have children that are in their 20s, you know, and I, just watching mine and others, you know, students at this university, they will not take this. You know, this is, they will just not accept it. You know, they will just, you know, all the talk about, you know, patient agency and consumerism, okay, sure, but I want to have it on my phone. I want to have, you know, this done. I want to, you know, just do this very differently. So how about something from bottom up? How about what's your view of clinical integration networks? What is your view of the IPUs? What is it, you know, that we can actually gain from this? You mentioned, you know, some of the pharma and others, the competitive encirclement that's unquestionably happening. Walgreens, Amazon, you look around, right? You know, so what is the learnings? What is the open door in this environment?
Yeah, if you don't mind me.
No, please, please.
So
Is it
this
your
is
friend
what,
or is it you?
this is me,
Oh,
not
good,
my
good,
friend.
good. Optimism.
This is, I am most excited about this for healthcare, and I think this is flourishing. Post-traumatic growth for our industry means that we come out on the other side of the hardest things we've been through as a country, as a world, as a society, and start to do things different. And I think partnerships will help us do that. And I think that big tech and AI and the impatience of our consumers and our kids is a beautiful thing. I actually, when I interact with young people, I have a lot of hope for the future, because I really think that we are being pushed into that which we need to be pushed to. The notion of scheduling an appointment with a phone call, I mean, my kids would think that was heresy. I mean, it was just like, what is that? The notion that they arrive and they have to wait, and that we build rooms dedicated for waiting doesn't, you know, work for folks either. And so how do we get to the other side where, you know, we have partnerships that ensure the data from Amazon Alexa, my kid has a cold, what do I do? Feeds us with real information, because while a lot of care can be delivered, you know, in tech-enabled settings, virtual care, there are some things that need to be trended and understood, because they're actually a bigger, more serious issue that is beginning to emerge in a patient. And so those connections, so that we can ensure, and for me, it's through partnerships. And I'm really excited about what's possible there in partnerships, because not one of us is going to have all the resources to invest in the technology. The important piece of it is to remember there's a whole ecosystem, and while Walgreens and others, and I'm proud of CVS and Walgreens and all that everybody's doing, when things get really serious, you'd want your health data to flow in a way that connects to your hospital care should you need it.
Very good.
Yeah.
And I think, because I want to open this to the questions from the audience as well.
The one thing I would say is, and I think this is absolutely an area where payers can partner with providers in that. The last thing that we want is for payers to be off investing in these same capabilities as providers are, again, duplicating. How do we, again, we all see you're right, the consumers are going to push us there. God bless them, they should. Push us into where other industries have been, but this is another area, as we talk about, where are those commonalities between what we see as being good disruptors, but we can disrupt too. You know, we have to own the disruption, not just outside in. You talked about inside out from a DEI and B perspective, yes, and outside into from a business model change, we have to own that as the legacy, if you will, too.
I
So
like
I
that.
just
You know,
had
this
that.
existential accountability.
Yes.
It's us.
Correct.
You know,
That's right.
Okay, good. All right, questions.
Yes, we have questions back here, so we're going to start. But
Go.
friends, we only have like 10 minutes, so we're going to make this.
I'll make this quick. Thank you for your presentation today. I testified in the House last week on health care, and I won't tell you what I said, but I have been treated for 360 ablation, where they go around your stomach. And I have kind of a health care issue in that I started out with U of M Fairview and then was told I had to give up my internist. And they started me on a generic drug that didn't work when I was supposed to take the full prescription drug, but insurance wouldn't pay for it. So that's my question. My insurance is deducted out of my check a month, which it should be. But if I'm paying, don't I have a better choice than this? Because I'm having more procedures than I think I need to be if I would have taken, versus if I would have taken the full drug as opposed to generic. Thank you.
Did you hear that up front?
Not
Where
well.
the question is essentially, if you're paying for your insurance, how come you as a patient don't have more say in what type of drug you get and what procedures you have access to?
Yeah, I mean, I think it's a little bit of both. So, and I actually am going to come at this from a clinical perspective as well as a business perspective. I think that paying for insurance 100%, right, is about making sure that you have access to the care that you need. And I think that there is so much happening, particularly in the pharmaceutical area, in procedure areas, that as a patient myself, doing that in partnership with my physician to understand what is best for me, sometimes may differ, right? I think that has to be a partnership with your provider. And it goes a little bit back, Lisa, to what you said about that is longevity. It's that relationship with your provider that you can have the conversation to say, trying different drugs and medications. So there's a lot that goes into the question. Part of it's about, is it the right medication? Sometimes, you know, we're one of the only countries in the world, I think, that a lot of time on the TV is spent with drug advertising, which may or may not be right for you. So I think that part of this is about relationship with your provider. Part of it is certainly from an insurance perspective. There are, you know, without question, there are things in place from an insurance lens to help with cost containment. So if there's generics available, for example, typically to start with those first. So without knowing your specific question, it's hard for me to answer it, but it is a partnership. Yes, you're paying for insurance, and how do you partner with your physician to make sure that the treatments you're getting are the most appropriate, medically necessary, and the medications you're on are the best for you as well. I don't know, Lisa, if you add anything. I think it's
good.
it's a partnership.
All right.
All right.
Yeah, thank you. Kind of related to that is this idea of value and value-based care and payment. I think the current models really are still basing value for the economic drivers. And so I'm really curious to your thoughts. You know, everyone mentioned kind of health equity or something to that effect at the beginning, but then we kind of got away from that. And so how do you really make a value centered around the community and the patient, and that their values are what is driving a value-based arrangement? And how do you do that in a way that addresses health equity, knowing that there's so many communities that have been left out of our current system?
Maybe thank you for that question. One of the things that we always have to start with, and we need shared accountability if we miss, and that is understanding our patients. Personalizing medicine, there's something genomic there, but there's also personalizing medicine to preference, to needs, to traditions, to understanding. Social determinants of health screening is a step, but the other step is really being in deep dialogue. And it's another area I'm actually most optimistic about the future of medicine, and that is all of you are having different expectations for being a partner in care. And so what I would hope and expect, and it's what I want for myself, it's what I want for my family, is to be able to show up with that conversation and dialogue that says, these are the things that matter to me at this moment. And part of that is early in prevention, And the other part of it is helping our clinical colleagues have what we call serious illness conversations. We're really, really trained to do everything possible to sustain our definition of improved life. Well, I think our patients get a say in that, and helping our providers understand the conversations to understand those preferences and make sure that we are personalizing to the needs. So I think you're spot on that as we think of, you're describing values, what I hear in a broader context of personal values and cultural context. And I think when we were describing value-based care, it was quality, cost, experience, and both are needed. Thank you.
All right, we've got another question here. Hi, thanks so much for being here today. I'm interested in the big picture and interested in your perspectives on how long do you think the United States of America will continue to coddle the concept of capitalism in an industry that does not really allow for a true market to exist and people don't want to shop?
Okay. Did you get the last part of the question?
I'm not sure if I caught the question.
Yeah.
Did you catch it, Dr. Tolar?
A part of it,
okay.
How long the capitalism is going to be ruling an environment that is not,
okay.
Permissive to the market behaviors. And, we talked a little bit about this, and I think not very long, because I see those that are older than 65, and there are many of them, and then I see the 25-year-olds to 45-year-olds that are starting their family and starting to be, responsible for this, and they will just not take it. I would, though, take, again, as one of the people in the room, perhaps, that has actually grown up in a totalitarian regime with communist view of medicine, I can tell you that this is not the answer. That's a short, description of that. The capitalism, in my opinion, is not the culprit. It is the lack of transparency, the inability to make choices based on the preferences, on what is, your time in the disease, have the patient-physician alliance that we all seek, that really is the key to this. And going back to our introductory comments, it is actually not that we don't know what to do. We just don't want to pay for it, because you don't have to go much further than Norway. I'm not saying that we are Norway, but you look at Scandinavia, for example, or some other countries, they figured it out. They just would ask me, to pay a lot more in taxes to get schools free, housing free, all these safety nets will be built, but the part of American experiment, which is glorious, in 3 years we'll have 250 years, is that ability to make these choices individually. And there are glories of this and there are demerits of that.
All right, Dr. Tolar, over here. We have one more question, our last question from one of our students in our B board. So take it away.
Hi, thank you so much. So me and my peers on the behalf of Carlson Student Government, we're wondering what attributes of the United States healthcare system do you think create a system where prices for healthcare are many multitudes higher in the United States than in other comparable countries? Somewhat of a follow-up to the last question. Thank you.
So what are some of the
pricing attributes in our country?
That's a really good question. I think that, pharmacy has to be discussed. I think that we know that the cost of medications in the United States is far and away exceeds what it is in other countries. So we are, in essence, subsidizing other countries' access to affordable medications, period. So that's a huge part. If you look at just the trajectory of healthcare costs and the percentage of the costs that are tied to pharmacy, it's exploded, specifically in specialty pharmacy. So medications that are very, for very specific, healthcare issues that are wonderful, curative, but the cost of them can be millions of dollars per treatment that we're paying in the United States. So I think pharmacy is one that just stands out, if you will, very distinct from other countries. as a driving issue. I do think that some of our fundamental things we've talked about today, a system that was structured and set up on paying for volume over value can lead to overutilization. We know that that's the case. So that has, I think, also led to that. And then I would go back, we're talking about public health a bit. And as I worked in public health nursing at the local level for a few years, how do we help people get engaged in their healthcare earlier? We are in a very individualistic society in the United States, we are. And I used to actually meet with my public health nurses who would quite frankly be wringing their hands over the decisions that someone may be making that was clearly impacting their healthcare in a negative way, which also then would lead to cost, right? And we would say at the end of the day, they have the right to make that bad decision. They have the right to make the bad decision. So how do we help them make a decision that helps them, right, within their value system first and foremost, but how do we help people see healthcare as something that they have to take a greater role in an active way? So I think there's many, many levers, but those are just two I would highlight.
Yeah, the only thing I want to add, because Dana's remarks are completely spot on, for all you students, choose a career in healthcare.
Yes,
I'm so glad
growing.
you're here. All right.
All right, thank you everyone very much. This has been, Dean Zahara is gonna close, but again, my admiration for these two women and what they represent is immense. I'm grateful to you for coming, and remember, you are the shoulders on which the future of your children, my children, grandchildren rests. So we, as you both said, we own the problem. We will not be able and shouldn't be allowed to kick it down to the next generations. Thank you.